the session on previous year MCQs for the subject Public Health Dentistry. So I'm Dr. Shilpa, your mentor for Public Health Dentistry. And I've shortlisted 20 questions, 10 from previous year NEET and 10 from previous year INI-CET papers. So we'll look into the topics which needs a little more detail, maybe which we have discussed here and there in our doubt solving sessions, which I felt I should add and go into detail here. So the first question is, which of the following will lead to selection bias? So is it selecting a sample from a university and asking their view on lowering the age of consumption of alcohol? Is it selecting sample from a university and taking a survey or something? Is it telephonic questioning? Is it if you do a questionnaire study? Or is it selection of participants from a dental hospital for assessing prevalence of dental caries in that state? So selection bias will happen when we obtain a sample from a population in a way it is not representative, and the findings we can't extrapolate in a valid way back to the population. So when we select participants from a dental hospital for assessing prevalence of caries, so definitely that will lead to a selection bias, right? Because when you visit the dental hospital, there will be already the people there will be coming there with some dental problem that could be attributed to caries. So how can we select a population, a sample from the population which is a dental hospital? That can't be, because it will lead to selection bias and increase the prevalence that you get in the results of that study. So that is the choice. That is, when you select sample from a dental hospital to assess prevalence of dental caries in that state, that is a clear example of forming a selection bias. Coming to a related topic, that is, we'll go into randomized controlled trials, that is study design in which participants get subjected to only one type of treatment during a course of a study. So is it a crossover design or a parallel design or a balanced design? So block study it's just a confusing term, whereas we'll definitely have to look into the options. Is it a crossover study design or a parallel study design? Question is study design in which participants get subjected to only one type of treatment. So the answer is parallel study design. We'll look into the flow chart here. Suppose we have a group of patients. Two types of randomization is two types of allocation is done here. In the upper half, you will see two groups of patients. Students in a randomized control trial, this is an example. It could be three groups of patients also. But what is important here is they are exposed to a particular treatment, a specific treatment only. Suppose if group A is exposed to treatment X, group B is exposed to treatment Y in this portion, the upper half portion which I'm showing, which is a parallel study design of randomized control trial. They are observed over a period of time and the outcome is compared. Whereas here, when the random assignment of the treatment is done into the study groups, first group A or B will be allocated to the treatments just like the parallel design, but after a period of observation, there will be an interchange in the treatments. This is the crossover study design. So it is important that there will be a washout period and then the crossover will be done, and again a comparison will be done among the groups. So to look into little more detailedly, so a parallel design, also called as a parallel group study, compares two or more treatments based on the study groups or the arms that are there. So the participants are randomly assigned to either group. That is the treatments that are administered and the results are compared. So as you know, a randomized controlled trial is a gold standard of phase 3 of the clinical trials. The hypothesis is confirmed in this type of study design. So for a parallel study design, other names can be include non-crossover or between patient study design. All groups receive completely separate treatments in a parallel study design. That is, Group A will receive treatment X, Group B will receive treatment Y. This is a parallel study design. So this is appropriate or beneficial when we have a disease or disorder where you can see the chance of progression during the time the study is taking place. And one thing is, at this time, because exclusively you're allotting the treatments, it can be a little expensive. Whereas in crossover study design, as I told you, first the group A will receive treatment X, group B will receive treatment Y, and then a washout period and interchanging will happen. Advantage is that participants act as their own controls. Whereas disadvantage in crossover designs is that, as I told, there can be a carryover effect. Example, you think about a mouthwash. That is why you need to have a washout period before the crossover is done. So in case you want to avoid the carryover effects, then a parallel design is preferred. So that is about this question. We'll come to the next question. In a study, this is on randomization. Two groups are randomly selected such that both the case group and the control groups have equal number. What type of randomization is this? So quite a few times this doubt was asked, so I thought it is appropriate to put up this question. You have two groups. The question is regarding what type of randomization. It is regarding the randomization technique that is used here, where the case group and the control groups have equal number of samples in each group. So what type of randomization is this? It is block randomization, students, because in block randomization method, especially when you have relatively smaller sample size and you need equal samples in each group, this is a method to randomly allocate the participants into the groups, which results in equal sample sizes. That is block randomization. Whereas simple randomization is a single sequence of random assignments. So you have your sampling frame and you are randomly allocating the participants to fall into either study or control groups so that they have an equal and known chance of getting allocated into the either group, so that there is no selection bias. There is complete randomness of the assignment of a person. Methods include just like a flipping of a coin. So, you know, there is an equal and known chance, but unbiased. It could be heads or tail. Heads control, tails treatment. Example. So this is an example of simple randomization technique. So one thing is, especially in small sample sizes, there can be unequal samples in the groups allotted in a simple randomization. Whereas in block randomization, this is not there. There will be equal sample in either groups. This happens in the unequal participants in simple randomization happens especially in a small sample size. Whereas, what are the other choices? Stratified randomization. The word stratified, straight up. So when you have a group of population where you have to balance few variables or few heterogeneous population is there, you have to keep a balance between maybe the age or the gender, or you have to divide into strata based on gender, then male and female, and then based on those variables you will make the strata, then randomization will be done. So you need to balance these variables. So dynamic randomization is the stratification factor levels, which has a balance, is also looked for in dynamic randomization, which is related to stratified randomization. So don't worry. First thing you need to remember is that block randomization has equal samples in each of the groups. And in simple randomization, you can see this figure. The imbalance in sample size happens, especially in small sample sizes in simple randomization. Next question. For prevention of tobacco chewing among tuberculosis patients. So you have a question that in TB patients, you want to prevent tobacco chewing. Which of the two programs were combined by the government of India? So you have few choices here where NOHP is National Oral Health Program and COTP is Control of Tobacco and Other Products Act. So we want a program here. So revised National Tuberculosis Control Program plus National Tobacco Control Program, that is choice A, were the two programs which were combined by the government of India because, see, in TB patients, there is a high comorbidity when they are tobacco consumers because tobacco smoke contains chemicals that causes disturbance in the lung bronchial surface. So because of this, it was seen that 38% of TB deaths is associated with tobacco, and there is in TB patients, there's a higher mortality among smokers up to 3 to 4 times higher. So that is why the revised National Tobacco Control Program was combined with the, National Tuberculosis Control Program was combined with the National Tobacco Control Program to reduce the burden of TB. Next question is related to ICCMS protocol. So this is related to the ICDS about which I had spoken recently. So ICCMS protocol is used for, is it preventing infection, or is it related to PPE kits, or is it caries risk assessment or caries management? So it's not infection control. Caries, related to caries, it's not a per se, it's not a risk assessment. It is a caries management. So it has overall protocol for caries diagnosis, prevention, and restorative procedures. It was got about as a follow-up of ICDAS. So International Caries Classification and Management System is a mission adopted by the Temple University Caries Management Pathway. So if ICDAS came in around 2002-2003, this was after 2010, this followed. That is the ICCMS, International Caries Classification and Management System. So it has levels and assessment of caries staging. So the conventional cavitated or non-cavitated, we have moved much more than that. So we are not even prescribing to use a curved probe. I think you know we don't prescribe the use of explorer even in detecting caries because it's a continuum now from the non-cavitated to the extensively cavitated lesions. So the 5 keystone levels here to assess caries staging and caries activity, caries risk, diagnosis, comprehensive care plan, and also the outcome analysis of the restored cases. So even the follow-up and everything is included in ICCMS. So it has, if you have the ICDA scoring here from 0 to 6, so up to 2, up to 0 is of course sound, 1 to 2 initial stage, 3 to 4 moderate decay, 5 to 6 extensive decay. So they are also a comprehensive care system where they are population focused, clinical research focused, and prevention focused. Coming to the WHO 2013 assessment proforma related question. WHO in 2013 did oral health status assessment on adults with which index? So one index listed here is used in the WHO 2013 proforma. And the index, I think you guys know it, it is the modified CPI. So I will tell you a few points under modified CPI. That is a modified community periodontal index. In the 2013 proforma, the modified CPI is used. The periodontal assessment is done using indicators, that is gingival bleeding and pockets, periodontal pockets. presence or absence is checked. And of course, loss of attachment is checked. Presence or absence of gingival bleeding, presence or absence of periodontal pockets, and loss of attachment. One thing is, because they told, because dentition status is full mouth, this periodontal status also we have to assess in a entire dentition. Then below 15 years, we don't check for pockets and loss of attachment. CPIT&C probe is used with the black band from 3.5 to 5.5 mm and additional ring set 8.5 and 11.5 mm. Calculus is not recorded as it is considered per se as not a disease. This is what is mentioned under modified CPI for the 2013 WHO Proforma. And see, loss of attachment is of course the, the sextant wise index teeth. That is how only it is assessed. But the periodontal pockets and gingival bleeding is assessed for the entire dentition. Presence or absence is assessed. Coming to the next question. Discrete value at fixed interval time as shown in the figure. So the figure is shown here. What is this figure? So it represents discrete distribution. So it is not normal curve. It is a Poisson distribution. So you can see here lambda equal to 1, lambda equal to 4, lambda equal to 10. What is this? These are the events. So mean number of events is represented by the lambda. So it is a Poisson's distribution is a discrete probability distribution that expresses the probability of given number of events occurring in a fixed interval of time where a known mean rate is there and they occur independent of the time. For example, number of head injury patients admitted per day. So the value will take on as 1 patient, 2 patient, like that. So it expresses the probability of given number of events occurring in fixed interval of time. Now we come to a calculation. This was also asked as a doubt recently, so I want to clarify it again with the method of calculation. Mean value is 10. Variation is 4. What is the coefficient of variance? COV, coefficient of variation. Okay, don't get confused. The formula here, please remember, standard deviation square is variance. So we have variance as 4. So standard deviation square is variation means 4 is 2 square. So standard deviation is 2. So then you just have to apply the formula coefficient of variation. So we wanted standard deviation from the variance. Standard deviation square is variance. As variance is 4, standard deviation is square root of 4, that is 2. So coefficient of variation is 2 by the mean, that is 10 into 100, that is 20%. So coefficient of variation measures relative variability among two variables. We have already discussed this, but because there was a doubt in the method of solving, so please remember this here. So in this session, few points I would like to highlight. So here, please remember, standard deviation square is variance. So the moment you remember this, you get your answers with your formula. SD square is variance. Now we come to one which I had discussed in my live class towards the end, but we'll go into it again. Meta-analysis is most commonly represented by. So is it Prisma? Is it forest plot? Is it consort? Or is it Kaplan-Meier graph? So we will look into, I know you know the answer, students. It is forest plot, which represents a meta-analysis. We look into forest plot. A forest plot is also known as blobogram. It is a graphical representation of the results of pooled studies. It is a statistical analysis is done by meta-analysis. The graphical representation is done in forest plot. So then what is a systematic review? Systematic review and meta-analysis, students, are in the highest level of hierarchy in the evidence-based pyramid. Systematic review is the way to gather all the evidence in a way you are analyzing the results of, you have a particular question in your mind and you gather the studies related to that question and you analyze all the data. You analyze how each study is done. You analyze all the data and summarize the results. Along with all the studies, you summarize the results and look if you get the answer to your question. So that is why, because clinicians want to be most up-to-date and evidence-based, systematic review and meta-analysis are highest in the evidence-based hierarchy. Now, meta-analysis is the statistical pooling of results of these pooled studies. And the graphical representation of the individual results is given in this form of a forest plot. So, you can also see how heterogeneous these studies are, whichever you have included. So, it is a quick visual representation of the overall effect estimates, and also you can study the heterogeneity, and therefore it is a very powerful tool. Now, let us look into a few studies. I've quoted the study here. Let us look into the forest plot, which has been used as an explanation. This article itself is used to explain forest plot. It has been taken from that article. So students, you can see the study details are given in the first column. Column 1 has the study details. The interventions are given in the column 2 and the 3. Weightage is given in column 4. Whereas I would like you to particularly see this column 5 and column 6. So here the risk ratios or the odd ratios or the relative risk, whatever it be, in a binary distribution, it will be given here. And the outcome in graphics is given in the last column. So for each study, you can see a line with a box in the middle, and then you can see a diamond. So we'll call this blue as boxes, and the black one we'll call a diamond, okay? And the vertical line is the line of null effect. This vertical line is a line of null effect, and each study included in the meta-analysis is represented by a box which gives the point estimate, and that horizontal line gives the confidence interval. The blue box is the point estimate. Horizontal line is the confidence interval of each study. Now, in relation to the line of null effect, if it is not touching at all here, then it will mean one type of significance. If it is crossing, it will mean another type of significance. So what is it? If it crosses here, if it crosses the line of null effect, the difference is not statistically significant. If it does not cross the line of null effect, for this study, the result is significant. So remember, if it crosses, not significant. I'll go back here. Here, the diamond. This is the pooled estimate. So the diamond here doesn't cross. So that means overall P is significant. Right? Can you see here? P is 0.001. P is significant. And it is not crossing the line of null effect. Whereas here, it is crossing the line of null effect, and you can see P is 0.15, which is more than 0.05. So the result, the pooled result is not significant. So remember, each horizontal line is individual study. The blue box is a point estimate. The diamond is a pooled estimate, and the width of the diamond also shows the confidence interval of the pooled result. So the width also shows the confidence interval of the pooled result, whereas here, the width of this box indicates the sample size. If you can see one box is bigger, means sample size is more. So I think I've told you a lot of things related to forest plot as of now. So each study included is represented by box, that is point estimate, horizontal line, 95% confidence interval, and the diamond, this is the black box, indicates the fold estimate. Now, one more thing, students, heterogeneity. Please see here, I square is 87%. So that means that there is a high heterogeneity. So 0 to 40% not heterogeneous, not very significant. 30 to 60% moderate heterogeneity. 50 to 90% substantial heterogeneity. So above that, till 100%, there is a high heterogeneity. So I square is the statistic that shows the heterogeneity. For example, in this study, I square is 87%. You can see that means there is a high heterogeneity among the studies. Whereas the other choices, preferred reporting items for systematic reviews and meta-analysis, PRISMA, it is an evidence-based set of guidelines for reporting systematic reviews and meta-analysis. Whereas CONSORT is consolidated standards for reporting trials. They are guidelines for reporting randomized control trials. So similarly, you have STROPE, observational studies, CARE for case reports, and so on. So they are guidelines for reporting. Whereas Kaplan-Meier graph is used to estimate the survival function. For example, patients living after a treatment, the survival, that is shown in a Kaplan-Meier graph. Just you need to know that much. So just a follow-up of the last question. Which of the following is not true for forest plot? It suggests heterogeneity involved in different studies. It is true. Ends of horizontal lines tells about confidence interval. That is true. We have already discussed. Individual study involved is represented by horizontal line. True. So what is not true? Individual sample size of study is represented by diamond. That is not true. It is a pooled estimate that is represented by the diamond. Now we come to our next question. On Dean's fluorosis index, students have specifically put this question so that maybe you can even take screenshots of my next two slides, because I'm going to talk about both the original criteria and the modified criteria here, and we will bust few concepts, clear few concepts here only. About Dean's fluorosis index, which of the following is true? Smoky white appearance is in moderate category. Is it true? So they have not even mentioned if it's original or modified. So it is important we know both them. So is smoky white appearance is in moderate, or white opaque areas at least half? Is it in mild? Is less than 25% in questionable? Of course, no. White few flecks in very mild. So what is the answer? So please remember, the moment the word mild comes, less than half of the tooth. I will show you in the next few slides few words that you can remember. So mild means at least half of the tooth. Let's go to this slide. Let's go to the original criteria. Dean's fluorosis index 1934. 0 is normal. Now we come to questionable. So in questionable, you have few white flecks, 1 to 2 mm in diameter. Few white flecks to occasional white spots. That is questionable. When the word very mild comes, it is less than 25%. So please remember like this. When the word very mild, it is small opaque paper white areas scattered less than 25% of the tooth surface. Whereas mild is white opaque areas not up to or that is less than at least any of these words of 50% or half the tooth surface. And there is also brown stains in the original category they have told. Whereas in moderate, one important word you have to remember is all surfaces are involved. Brown staining in all surfaces and minute pitting. And there is the smoky white appearance that is in the original criteria, and the moderately severe is the smoky white appearance. The original criteria of 1934 is a 7-point scale, including normal if you add, it is a 7-point scale, whereas the 42 modified criteria is a 6-point scale. So moderately severe is there only in original criteria, and smoky white appearance is told to be there here. So they combine moderately severe and severe to the severe category in the next, which I will show, that is the modified criteria. Before that, let's look severe. So there in severe, hypoplasia is very marked and deeper stains, extensive pitting is there in severe. So then we will see the modified criteria. Normal, the point given is 0. Questionable, the point given is 0.5. So here you have few white flecks to occasional white spots. Again, as I told, very mild, always you have to remember very mild less than 25%, mild less than 50%. In moderate, all tooth surface, one thing you have to remember, all tooth surface. And in modified, staining starts from moderate. And severe is hypoplasia, marked hypoplasia, all teeth affected, corroded appearance, pitting, and widespread brown staining. So that is the original and modified Dean's fluorosis index for you. Now we'll come to fluoride. Which form of topical fluoride acts by causing dehydration and shrinkage of the hydroxyapatite crystals? So they have told DCDP is formed, which is an intermediate, which causes dehydration and shrinkage of the hydroxyapatite crystals. Can anybody put up in the telegram which is this choice? So is it stannous fluoride, is it sodium fluoride, or is it acidulated phosphate fluoride? Durafat is the fluoride varnish. So this is related to the first 3 choices. Sodium fluoride application technique is also called as Knutson's technique. Stannous fluoride application technique is also called as Muller's technique. And acidulated phosphate fluoride, that is Brudivold solution, it is the Brudivold's method. So DCDP is seen in choice C, that is acidulated phosphate fluoride. So dicalcium phosphate dihydrate or DCPD it reacts with, it's an intermediate product that is formed which leads to dehydration and shrinkage of the hydroxyapatite crystals, so that there is a good uptake of the fluoride, because it forms this intermediate product. It allows the fluoride to penetrate into the crystals more deeply, and this leads to also calcium fluoride also is formed, and fluoride plus hydroxyapatite, fluorapatite is also formed. This DCPD is highly reactive and starts forming immediately when APF is applied. One more thing you need to know is this is a paint-on technique. You have in a solution form, and in a gel form you have a tray technique. So methods of fluoride delivery, you have topical fluoride, self-applied like dentifrices, mouth rinses and gels. Professional applied, in varnishes you have Durafat, that is 2.26%, flow protector, that is 7,000 ppm, have Carex, which is 1.8% fluoride, fluoride solutions, gels, paste, devices containing fluoride. Then you have systemic fluorides, that is, you have community waters fluoridation, school water fluoridation, salt and milk fluoridation, and fluoride supplements. Now we come to the other choices in little bit more. That is, as I told, sodium fluoride. How do you prepare? Method of preparation of 2% sodium fluoride. You mix 20 grams sodium fluoride in 1 liter water. And minimum 4 applications, that is weekly. It is done at 3, 7, 11 and 13 years. Caries reduction is about 30%. Then Durafat, as I told, it is 2.26% fluoride. Caries reduction has been seen both in permanent and primary dentition. In permanent dentition, 30 to 40%. And in primary dentition, it is little bit wide, that is 7 to 44% in primary dentition. Again, a question on topical fluoride. Which form of topical fluoride has the highest anti-cariogenic activity? Is it amine fluoride, stannous fluoride, APF, or sodium fluoride? So this is a topical fluoride which has some side effects also, but the anti-cariogenic activity found is maximum. So that is stannous fluoride. So the disadvantage is that it causes staining of teeth. So as I told, it is the Muller's technique. It is used in 8 and 10% concentrations, which is equivalent to 2 to 2.5% fluoride. So how do you prepare? For preparing an 8% concentration, you have to dissolve 0.8 gram in 10 ml. So when we told sodium fluoride, we told 20 gram in 1 liter. Here, if it is in 10 ml, we tell it as 0.8 gram, leads to 8% solution. 10% solution is for adults, 8% is for children, but they have not seen much of a difference. Anyway, commonly used is 8% stannous fluoride. Now we'll see what are the byproducts. Yes. Now the byproducts are, that is a mechanism of action, in low concentration, tin hydroxyphosphate is formed, which is unstable. So that's why you need to freshly prepare the solution. And also it causes a metallic taste. That is tin hydroxyphosphate. At high concentration, calcium trifluorostannate and tin trifluorophosphate. Remember, the anti-caries activity is tin trifluorophosphate. That makes the tooth very less susceptible to decay. Also, calcium fluoride is also an end product. So it reacts with hydroxyapatite to form fluorhydroxyapatite. We'll also see this amine fluoride. So amine fluoride, Muleman and co-workers introduced in 1957. So one thing you need to remember about amine fluoride is, yes, it is anti-cariogenic. It holds fluoride for a long time, a longer time against tooth. That is one point for amine fluoride. Another one is antibacterial property. That is anti-glycolytic action, and it can reduce plaque levels. That is about amine fluoride. Then APF, which I have already discussed, paint-on technique and gel technique is there. Biannual application is there for APF. Now we come to a defluoridation question. Correct sequence of steps for Nalgonda defluoridation technique is, so it is jumbled up here: rapid mixing, sedimentation, filtration, flocculation. So I know by now you guys know this, because of course the sedimentation, filtration, is in a sequence, right? So it is rapid mixing, flocculation, sedimentation, filtration. because usually students know that sedimentation, filtration occurs together. Sedimentation, filtration. So rapid mixing, flocculation, sedimentation, filtration. So what is added for you to do the rapid mixing? And then how it forms flocks, and then it is sedimented and filtered. So what is added? Remember LAB, lime, alum or sodium aluminate, and bleaching powder. Lime adjusts the pH because H2O, water. When you add alum, H plus and OH minus, the H plus acidity to counteract, you add lime to make it neutral. Then bleaching powder is for disinfectant action. Alum aids in formation of flocks and gathers the fluoride, and sediments and filtration is done. So the process is rapid mixing, flocculation, sedimentation and filtration. Nalgonda technique is a low cost, done in easily available materials, right? Can be done in domestic level, that is household level and community level. When there is no acceptable way of defluoridation, this is the best alternative. When there are no defluoridation, expensive, high-tech plants, this is a very low-cost method which has gained a lot of acceptance. Only thing is the total dissolved solid should be below 1500 milligram per liter, above which you need desalination. And also raw water fluoride should range from 1.5 to 20 milligram fluoride per liter. In this range, this can be done. Coming to the next question on tests of significance. A researcher wants to compare the mean BP in male and female rats. So you have two groups, male and female rats, but three arms are there, three different drugs are there. Which statistical test will you use? So, is it chi-square test? Chi-square test is done on categorical variables. Paired t-test. Paired t-test is when same sample you check before and after. Student t-test is actually an umbrella term, but if you meet one sample t-test, what it is, we'll see. The answer is ANOVA. You have groups, you have three different allocations. Answer is analysis of variance. It tests differences among means of population by analyzing variation within the sample and also between the samples. So, please don't ask me why the full form is not analysis of means, because it actually checks the difference in the means by checking the variance. So, the full form is analysis of variance, okay? But the comparison is between the means of the three treatment groups. Number of independent variables. One-way ANOVA has one independent variable. Example, 20 patients' diastolic blood pressure is given. Then one-way ANOVA is used to compare the mean diastolic blood pressure in three age groups, because there is only one independent variable, that is the diastolic blood pressure. Whereas two-way ANOVA has two independent variables. 20 patients' diastolic blood pressure, here it is the age which is the independent variable. And when you have two independent variables like age and gender, you want to check the 20 patients' diastolic blood pressure. The two-way ANOVA is used to compare the mean diastolic blood pressure between age group, that is independent variable 1, and gender, that is independent variable 2. So with example, please remember one-way ANOVA, one independent variable. Example, age groups, one independent variable. Two-way ANOVA, two independent variables, that is age groups and gender. This is the example. Explanation of other options. So student t-test. So suppose you draw a sample from a population and you want to check the mean of the sample. Is it what you claim as that from the population that you have taken? So a method of testing hypothesis about the mean of a small sample drawn from a normally distributed population. So that is broadly when you tell it as student t-test. And I will come to dependent and independent sample t-test. Just to mention about chi-square test, it is used in the analysis of contingency tables. That is, it's a test of proportions when sample size is large. Paired t-test. Example for paired t-test. You have a group of diabetics. An anti-diabetic drug is given. So what is the difference between pre-treatment HbA1c level and post-treatment HbA1c level when administered with this drug? So that is the time you use the paired sample t-test or the dependent sample t-test, used to determine whether paired data of independent observations from one sample only, when each individual gives a pair of observations. So we'll discuss the other in this question. This is also related to tests of significance. A study was conducted to assess the association between oral hygiene instructions while the other group was not given. So you have a group where oral hygiene instruction was given and another group where oral hygiene instructions were not given, and the occurrence of caries was evaluated. So as I told here, clearly the answer is chi-square test. So chi-square test was developed by Carl Pearson. So you have oral hygiene instructions given, not given. So the data is measured in terms of attributes or qualities. So when you want to test the difference in the distribution of these attributes or proportions, chi-square test is applied. So significance of difference between two proportions is checked with the chi-square test. So this question is an example for that. Whereas unpaired t-test, that is independent sample t-test, is, as we saw previously with the example of ANOVA, that was a comparison of mean in 3 groups. Whereas if we had 2 separate groups where the mean values had to be compared, then you have the unpaired t-test to be applied. Now we come to charts. That is the method of data presentation. Chart with bars representing classes subdivided into constituent parts. So a bar is subdivided into constituent parts. What is the answer? So it's definitely not frequency polygon. So bars representing classes subdivided. So is it multiple bar chart or is it component bar chart? It is component bar chart. So we will come to that. So a bar chart is a way of presenting a set of numbers by the length of the bar. So width of the bar will be constant or same. Only the width will be same. Only the length will vary according to the frequency in each category. Bars can be horizontal or vertical, but the width will be same. The length will vary according to the frequency. So one thing is histogram, there is no spaces, whereas in bar chart, there are spaces between the bars. So you have a simple bar chart where only one variable is there. Example, percentage-wise prevalence according to age of a disease. Multiple bar chart, you will see in multiple means you will see bars together sticking to each other for different class intervals. Example, age group by survey responses. This diagram where there is a set of bars of same width corresponding to different sections. That time between the ages there won't be, between the together there will be some bars which are sticking together, then there will be a gap and there will be the next age group where the responses will be given. So that will be a multiple bar chart. So for each category of the variable there is a set of bars. Whereas in proportional or component bar chart, you have the individual bars are divided. So, for example, if you want to check prevalence of dental caries based on many variables between countries, or you're dividing one bar into age and gender or countries, so then you have proportional or component bar chart. Then histogram. In histogram, there is no space between the cells. So it is a frequency distribution that is depicted. Class intervals are on the x-axis and frequencies are along the y-axis. And when you draw a midpoint on the top of the histogram, when you draw a point on the mid region on the top of the histogram and connect the points with straight lines, you get a frequency polygon. A point is marked over the midpoint of the histogram blocks and they are connected by straight lines to get a frequency polygon. So when there is a larger sample size, then the polygon tends to curve. So that is your normal distribution is an example for that. Whereas pie charts, entire graph looks like a pie and its component represent the slices cut from a pie. The total angle is 360 degree, which represents the total frequency. So the different sectors of the pie correspond to the frequency of the variables in the distribution. But one thing is you can't represent two or more data sets because you have various frequencies which will be shaded in different colors and you have to provide an index for each color. That is a pie diagram. So bar chart, pie diagram, you have your pictogram. These are all for qualitative data, whereas histogram, frequency polygon, your line chart, ogive, these are all for quantitative data. Now we come to a question from IDA. An Australian dentist wants to become a member of the Indian Dental Association to take some of the advantages and the privileges. So what will be the membership given in a situation like this? So a foreign dental practitioner. So it could be, what is the name of the membership? Is it affiliated membership? Is it NRI membership? Is it honorary membership, or cannot be a member at all? So it's not NRI because foreign can be inclusive of NRIs and non-Indians also. And there is no membership called NRI membership for IDA. The answer is affiliated member. So an international dentist can join IDA as an affiliate member. It was founded, IDA was founded in 1946 by Dr. Rafiuddin Ahmed, known as a father of dentistry in India. It started as All India Dental Association, later renamed as Indian Dental Association. Now, honorary members are members with certain scientific and literary achievement. They are honorary members. Life members have to take the lifetime subscription. Of course, they are the dentists who have the recognized dental qualification, but with a lifetime subscription. Annual members, same, but with annual membership subscription. Direct members, when the word direct, remember students, it is not with the local body, it's with the state or the central. That is direct membership. Student members, that is undergraduate students from a recognized dental institute. And as I told, affiliate member is for international dentists. Again, with the, according to section 10, they should have the recognized dental qualification. That is about this question. Now we come to screening chapter. This was also asked as a doubt, students, so I'm putting it again. Lead time in public health is lead time. So we actually need to look into the diagram. I'll show you the diagram. Disease onset detection. This is a very initial onset of disease. Then you have the first possible point where the disease can be detected by screening methods. This can go on till the final critical diagnosis. So from first possible point to the critical time is the screening time. Beyond the critical time, screening test is of no use because then that is the usual time of diagnosis. So one thing, screening is done on apparently healthy. So they will not be symptomatic. That is why first point is disease onset detection, whereas screening test is from the first possible point to the critical, final critical diagnosis. This point is critical for screening. Whereas lead time is the advantage gained by screening. It is from the time you can detect it by screening till your usual, most symptomatic, usual diagnostic time. That is the advantage. That is the whole time period. It is called as lead time. So screening time is from first possible time to final critical diagnosis, whereas lead time is from first possible time to usual time of diagnosis. So the choice lead time is C, from first possible time to usual time of diagnosis. Please remember, beyond critical time, there is no use for a screening test. So screening time is from first possible time to final critical diagnosis, beyond which till the usual time is the lead time. Lead time is an advantage gained by screening. So once the screening time is over, there is nothing to be gained from a screening test. So these programs should be restricted to those conditions. For example, screening of oral cancer, screening of cervical cancer, screening, so many screening tests. It should be restricted to those conditions where there is a time lag between disease onset and the usual time. That is time lag between the disease onset and the usual time. Coming to the last question. In public health program, incremental dental care is provided after. So in this question, we will see incremental dental care and comprehensive dental care. Incremental dental care. So the doubt is, naturally you will have, is it 6 months or 12 months? Incremental dental care, it's provided usually for 12 months. And remember the children age group here, the child in the school, 12 months, you remember. In public health program, 1 year, that too in public health program, 1 year intervals are implemented. In private practice, 6 months is followed. Now, incremental care, increments, periodic care. Periodic care so space that increments of dental disease are treated at the earliest time. So remember, increment, periodic care, children, earliest time, consistent with proper diagnosis and operating efficiency, so that there is no accumulation of dental needs. Earliest time that prevents the accumulation of dental needs beyond minimum. So the word is gotten off the ground. You take the youngest available group you take in the first year, then one year, 12 months apart. So in the next year, one thing is funding should permit, resources should permit. So first you start the program by taking youngest available group in the first year. Then you take forward by adding the lowest age group, the youngest children, next class of children at the earliest available age until the entire child population is served. That is incremental dental care. Whereas comprehensive dental care, the word comprehensive, meeting the accumulated dental needs from womb to tomb, comprehensive. So any time a population is taken into a program, initial care is given. Then on a semi-annual or other periodic basis, maintenance care is given. So here in comprehensive dental care, your aim is to control pain. Also preventive services are there. Control pain, control infection, replace missing teeth, and provide maintenance care. Womb to tomb services. That is the comprehensive dental care. So that is about the PYQ session in this 1 hour, students. We discussed 20 questions, 10 previous NEET questions and 10 previous INICT questions. I selected these questions so that we discuss something which we know but in a different way, and we analyze few concepts which we would not have thought about so that it is clear, and some of the doubts were also incorporated, and I hope this is a fruitful session for you. Thank you. Any doubts? Please put up in the group if you want to ask anything. And anything else is there, you can also put up in the Telegram group. And as usual, you have me always solving your doubts, students. So please have a consistent approach in solving. And I'm really appreciative that you are also asking the doubts. And we will keep meeting up like this and going up to date with the last strategy which is coming up. That is solving maximum questions and clearing all the concepts. So I hope we had a fruitful session. Thank you.